So this is the audio portion, part 2, and on this section we'll focus on treatment planning. So we've done our assessments, we've done our dental hygiene diagnosis, and that's just to wake you up. And now we're going to do our treatment plan. So basically, a comprehensive treatment plan is based on your comprehensive assessments and your diagnosis. So basically, you've done all those assessments, you've analyzed the data, and now what do you recommend to your patient? So it's so what are you going to do now? So what does a good treatment plan accomplish? Basically, you want it to be individualized and based on your patient. So it should be individualized approach to dental hygiene care for every patient. You want to identify any of the problems that your patient had and try and create goals to solve those problems. It's an opportunity to discuss the treatment and what you're proposing to the patient, and you can explain the problems and establish goals. This is a super important time to make sure you're on the same page with your patient. And you want to base your treatment plan on up-to-date evidence. Evidence is another way of saying science and clinical trials that support positive outcomes for your patients. You don't want to be recommending a treatment that is not found to be effective. So you want to make sure that you're always providing up-to-care treatment. So basically, when we talk about evidence, there is a ladder of evidence, and you always want to use the highest and best data to drive your treatment. And we'll talk about this a little later in the semester, but basically, in a nutshell, you want to use really highly valued studies that are based on clinical trials, experimental design, those kinds of things, as opposed to maybe something that was done on beagles and had a good outcome in animals. That might be where preliminary research starts, but it might not really be relevant to high, treatment outcomes related to for your patient. So your treatment plan is a legal document, so you want to make sure that it looks professional and everything is signed. So if you go through this efforts of creating this beautiful treatment plan, you go over it with your patient, but they don't sign it or you don't sign it, then it's not really a legal document that it should be. So your treatment plan, it includes informed consent, and I'll explain a little bit later what that is. Prognosis, your prediction of expected outcome. It should include alternatives for treatment. You should specify the risks of treatment, and it should be organized in a logical sequence. So, informed consent, that's basically the nature of the patient's case must be described in understandable terms. So you want to make sure and explain to the patient what's going on in their mouth, and what you're proposing to do for treatment in ways that they understand. The patient should be allowed to ask questions, and the suggested plan and alternatives should be stated. So maybe an example of an alternative is you're proposing 4 visits for scaling that are going to be 4 hours long or 3 hours long. And maybe the patient has limited opening and really would rather have 1 hour visits, but more visits, but shorter. So that would be a good example of an alternative that is more palatable for the patient. So informed consent, you want to make sure the patient knows the costs. Generally, things are very, very reasonable priced, very good rates at Middlesex Dental Hygiene Clinic, but certainly when you're in private practice, things are very, very expensive, and it's very important that the patient understands how much the proposed treatment is going to cost before they get into it. Also time, and that's perhaps our biggest issue, is you guys give great care, but it is time consuming. So you want to be upfront about that. You don't want to, let's say you really think your treatment is going to take probably 4 visits, but you feel bad saying that. So then you're going to say, oh, I'll try to do it in less. That's really postponing a difficult conversation. It's much easier to have that conversation in the beginning than at the end. You want to think about how you value your time. What if I said, okay, guys, I'm going to add another day of class every week. We're going to add Friday afternoon. So instead of class 2 times a week, we're just going to add it 3 times a week. You'd be horrified, right? So just like we like clear expectations on our time, so do our patients. You want to make sure that you obtain a signature from your patient or parent if they're underage. And again, you want to explain the prognosis, what you likely expect from your treatment. And sometimes they could be adverse. Sometimes your prognosis is not favorable. Sometimes it's not great. Sometimes it should be good. But you want to try and give the best prediction you can. Risks. So many times when we do scaling, some of the risks are that the patient will then have dental sensitivity after our treatment. So you don't want them to be surprised by that. You want them to know what is realistic, what may be transient, and what may be a long-term problem as well. So we call these post-op instructions. So what to expect post-op after treatment, and those should be given to the patient. Here is an example of a post-op sheet instructions, and these are a list of the common things that may happen with dental hygiene care. So I've posted this on your Blackboard site, so make sure and take a look at it, read it, make sure you're comfortable with that. And we have copies in the clinic, so you always want to give them out to your patient and feel comfortable with explaining these issues. Let me know if you have any questions about those. So the factors that affect overall prognosis of a patient, in particular their perio prognosis, is age, their health history, smoking status, family history of periodontal disease, their oral hygiene status, and their compliance with treatment. All these things can make it more difficult to treat a patient. So some of the goals of your treatment might be, and there's a spot on your treatment plan where you're going to put the goal. So be mindful of some of these options. So it might be you need to eliminate contributing factors for your patient, eliminate periodontal risk factors that are modifiable. It might be eliminate predisposing factors, or it might be reduce predisposing factors or contributing factors. It might be reduce the etiological factor. It might be reduce biofilm. It might be control factors. It might be to eliminate signs and symptoms of the disease. It might be to restore normal function. Some patients, hopefully most of them, are in great shape, and maybe you want to maintain their health and maintain their periodontal health. You might be in a stable, the patient might be in a stable time period of perio, so you want to maintain that inactive state and prevent reoccurrence. You might want to reduce cariogenic factors. Maybe the patient has a high caries rate and you're trying to reduce the amount of new carious lesions. Your patient might be a smoker, and one of the best things you can do with your patients is help them quit smoking if they have an interest. Maybe in your treatment you want to create a smoking quit date. You might want to decrease plaque control record by 30%. decrease bleeding sites by 10%. It's always nice if your treatment goals are measurable, and then you'll know when you reach success or you don't. It's basically, your goals aren't a list of what you're going to do, they're what you hope to accomplish. So you want to make sure and document this on the treatment plan, and you're always assessing at subsequent visits and follow-up visits with your patient what your original goals were. And that's the component, the evaluation component in the dental hygiene process of care. It's closing the loop. You create these goals and then you follow them up to see if you've reached them. So in general, treatment planning in dentistry has a couple of different phases, and there is some structure to how we do what we do when we do what we do. So we always meet emergency needs of the patient first, and there's a couple of different names for that. It could be called preliminary care, priority phase, priority care, and that's basically if a patient were to have an abscess, they're in pain. Sometimes patients' jaws will lock, and they'll be left in a wide open spot, so you'll need to close the jaw for them. That would certainly be an emergency visit. Phase 1, another name for that is initial preps, initial therapy, non-surgical periodontal therapy. And this is patients who haven't had adequate dental hygiene care and usually need multiple visits in private practice to remove all the deposits. Phase 2 is surgical care. So whether it be a crown lengthening when you surgically lower the gingival margin to get better access to be able to do a crown or access subgingival caries, or it could be periodontal surgery or grafting. That would be called phase 2. Phase 3 is restorative or prosthetic treatment, crowns, restorations. And the last phase, and some people just maintain in this phase and just stay in phase 4, which is great. And that's really where you want to be. That would be the goal. So basically, this is the order of care unless unusual circumstances. This is generally the flow of how we treat patients. So you would always get things as clean as they could be in phase 1, remove all the calculus before you did surgery or restorations. So everybody wants everything as perfect as possible before you do surgery or a restoration. If you have, the healthier tissue is, the healthier it will be in a surgical situation. Okay, so here is basically, oh geez, that just wakes us up too, doesn't it? So here are some examples of different types of phase 1 or initial. This will include self-care, education for your patient. It includes debridement, scaling, root planing, non-surgical periodontal therapy. It has many different names. Correcting overhangs, antimicrobial therapy, minor, very minor ortho, minor occlusal therapy, and surgical would be surgery, regenerative, repairing mucogingival involvement, those kinds of things. Crown lengthening, as I mentioned earlier. Restorative, so this would be prosthetic, restorative, orthodontic, significant cases, splinting, occlusal therapy. And the last phase is periodontal maintenance procedures, and this is where someone's on a recare and they're staying pretty healthy. So that would be maintenance. So the goals of when a patient is in this, you're basically trying to prevent the occurrence of new disease and stabilize and prevent disease from reoccurring. And basically, you're always trying to make sure that you're evaluating your recare interval and you're keeping your patient so that they're coming in healthy. And that's the recall that will work for that patient, what keeps them happy, healthy and hopefully happy. Some patients do fine on a 6-month recall. Some patients need to be on a 4-month recall. Some patients need to be on a 3-month. In perio, I've had patients where I've seen them every 2 months, and that's what they needed to do to stay healthy. So everyone's different. You should individualize that. So you want to definitely consider some barriers that you may have when you're treating your patients, and you want to make sure and address them. A huge one is language, right? If you don't speak the same language as your patient, it might be really hard to convey the treatment, what they need, what you're recommending, the prognosis, the risks, and all those things. So we have some technology in clinic that can help you with that, and you'll hear more about that later, but that's always important to try and get over that barrier. Money, some patients, they don't have the money for the proper treatment that they need, so you need to try and help them, be an advocate for them, or come up with alternatives that might be better for them. Pain, whether it's perceived or real, it doesn't really matter, but it can always slow down your treatment. You must always think about stress reduction and lowering the stress for your patients, and thinking about sensitivity. Soft tissue sensitivity can often be helped with topical anesthesia, but sometimes with dental sensitivity. Or kicks can be helpful sometimes, or you just need local anesthesia to block the pain from the tooth, to keep your patient more comfortable while you're doing your dental hygiene care, because that can certainly slow things down. So you always, whenever you need pain control and it's an issue, it's always going to add time to your treatment plan in multiple visits. So I think if you just plan on that, it helps, because oftentimes patients are, clinicians are surprised at how much it slows down things. So creating your treatment plan. You want to think about the order in which you do things, and you want to avoid like always starting on tooth number 1 with your scaling. You really want to think about why you do what you do. So you want to think about sometimes you want to start in the most difficult area, especially if it's going to take 5 visits for your instrumentation. Each visit, you'll get another crack at that difficult area. So sometimes, or most of the time, I like to start with the most difficult. If I have a patient that's really sensitive or uncomfortable or anxious, sometimes I like to start with the easiest to kind of ease them into care. So I might start with what I think is going to be easiest for me and the patient, as opposed to the most difficult. So it really just depends on the patient and what's going on. Excuse me, of course I'm sneezing. Okay, so your order is going to depend on your severity of your perio condition, how difficult the general health of your patient, their motivation, cooperation, the prognosis, the patient's needs and desires, and what they want. So you're trying to pull all those things together. So consider the sequence of your therapy. That's what I just talked about. And make sure that you can provide a rationale for why you do what you do. And you want to think about how many appointments. Basically, it's probably best to aim on the high side, because you can always say, oh, we finished treatment early. No one will ever get mad at you for finishing early. But patients can easily be disappointed if all of a sudden you're adding visits and they thought they were going to be done. So when in doubt, aim on the high side. and you're going to base it on the individual. Many times it's how much deposit, how much calculus you have, and how deep the pockets are, and what's the tenacity, what's the mode of attachment on the is it on the pellicle? If the calculus is on the pellicle, well, then that's easy to remove. We love that. When it's interlocked within the tooth, the mode of attachment is going to be a little more difficult and take a lot more time. What are the clinical attachment levels? Are you working in clinical attachment levels of 5 and 6 or 2 and 3, right? Definitely the deeper you are, the more surface area you have to cover. Schedules, length of appointment, you might have a patient who can't open much, fear, all those things can add. Health history, sometimes you have a pre-med patient and you can only see them between you need to wait till 7 to 10 days in between pre-medding. You can't, see them every day. So all those things need to, you need to be mindful of pulling all together on the treatment plan. So a basic treatment plan, just to kind of get you started, where we, generally we begin with education, and that should be individualized for each person. But you always want to start with self-care and education, because it's the most important thing. You don't want to end with self-care, and as the patient's, getting ready to run out of the chair, you're going over the most important thing when they least have interest in what you're talking about. You do it in the beginning. If the patient has desensitizing issues, you would do that in the beginning. Then you debride, and we typically end with fluoride. That's typically the last thing that we do. Supportive treatment, sealants, amalgam polishing, Arrestin, mouth guards. You will learn how to treatment plan those within for your patient. But that's generally a light overview and the sequencing of the care. But again, it's always individualized for your patient. So you're also going to make your referrals, any referrals that the patient needs, whether they need perio, ortho, that will all be on your treatment plan. And you're going to include those on a dental hygiene report. That's a 2-page paper. It's got a carbon copy. We put one in the record and one for the patient or the dentist. And that's basically a communication piece so that our patients, their dentists know what we're doing when they saw us, so we can have a better communication with their other providers. So this is, you'll also give your patient the post-treatment instructions, and on your treatment plan is where you'll decide if your patient needs a reevaluation to evaluate the host response, self-care, and you'll include that in your treatment plan. And you always want to discuss everything with your patient and your instructor, and you get all signatures on your treatment plan. So when you're presenting a treatment plan, to be honest, it's an art form and it takes a while to get comfortable doing that. So don't be discouraged if it takes a little while to do, but the more you do it, you will get better. And the more comfortable you are before presenting, that will be helpful. So you want to make sure and iron out all details with your instructor first. So review your plan with your instructor, and then you'll feel a little bit better when you're presenting it to your patient. And eventually you will feel very confident, but patience is the key with treatment planning. It is a very, very challenging skill set, and you'll always be building on it in dental hygiene school as well as private practice. It's really a never-ending skill set that you're always working on.